Welcome to the October issue of the podcast of the journal Endoscopy. It's the official organ of the European Society of Gastrointestinal Endoscopy. As usual, we present the summaries of 3 articles which are appearing in the October issue of the journal. We hope you find them interesting and relevant to practice. Colonoscopy has been proven to reduce the burden of colorectal cancer by preventing up to 60 to 80% of incident lesions, and this benefit is essentially related to adenoma resection. As the endoscopic appearance of polyps under white light is poorly reliable in predicting the presence of adenomatous tissue, up to now, all of the detected polyps have been removed and sent for pathologic assessment. Post-polypectomy surveillance timing is driven by histologic features along with size and number of resected adenomas. However, the role of advanced histological features for guiding surveillance is being debated, as villus component or high-grade dysplasia at index colonoscopy are inconsistent predictors of subsequent advanced neoplasia. This might suggest that an endoscopic diagnosis of adenoma might allow the determination of polyp management and surveillance interval, particularly in patients with small polyps less than 10 mm in size, in which the advanced histological features are uncommon and the prevalence of invasive cancer is very low. Real-time imaging technologies have shown promising results in discriminating adenomatous from non-adenomatous polyps. In particular, narrowband imaging (NBI) allows the visualization of density and shape of surface microvessels as dark brown structures, and it has shown a sensitivity ranging from 83 to 97% and a specificity from 64 to 100% across the studies for the diagnosis of adenoma. The application of this technology in patients with small polyps, which constitute the majority of those encountered during colonoscopy, could promote the practice of leaving in obvious non-neoplastic polyps and allow a resect and discard approach to clearly neoplastic ones, which have a low likelihood of harboring advanced pathology. This strategy, where decisions on patient management are driven only by the in vivo endoscopic assessment, could potentially exert a significant impact on colonoscopy practice by decreasing pathology-associated costs as well as polypectomy-associated costs and complications. Paggi et al. Investigated whether the systematic use in everyday clinical practice of the resect and discard strategy allows the accurate prediction of post-polypectomy surveillance timing in patients with small colonic polyps, and report their findings in the paper entitled Resect and Discard Strategy in Clinical Practice, a prospective cohort study, which is published in the October issue of the journal Endoscopy. Narrowband imaging, NBI, has shown promising results in discriminating adenomatous from non-adenomatous colonic polyps. In patients with small polyps with less than 10 mm in size, the application of NBI within a resect and discard strategy might allow post-polypectomy surveillance intervals to be determined independently from histopathology. The aim of the present study was to assess the feasibility and safety of this approach in routine clinical practice. Consecutive colonoscopy outpatients with one or more polyps smaller than 10 mm were prospectively included. Each polyp was categorized by the endoscopist as adenoma or non-adenoma according to simplified NBI criteria, and future post-polypectomy surveillance interval was assigned accordingly. Following histopathology, post-polypectomy surveillance interval was subsequently reassigned, and the accordance between endoscopy and histology-directed surveillance strategies was calculated. Among 942 colonoscopy patients, 286, 30.4%, with only small polyps were included. In total, 511 small polyps were evaluated. 350, 68.5%, were adenomas, and 18 of these, 5.1%, had histological features of advanced neoplasia. For the in vivo diagnosis of adenoma, NBI sensitivity, specificity, accuracy, and positive and negative likelihood ratios were 94.9%, 65.8%, 85.7%, 2.8%, and 0.08% respectively. The endoscopy-directed surveillance strategy was in accordance with the histology-directed strategy in 237 of 286 patients, that is 82.9%. In 9.8% and 7.3% of patients, the endoscopy-directed approach would have resulted in early and delayed surveillance, respectively. The authors conclude the resect and discard strategy seems to be a viable, safe, and cost-effective approach for the management of patients with small polyps. However, caution in the application of the strategy should be advocated for patients with polyps 6 to 9 mm in size and those with right-sided lesions due to their malignant potential.